Hi everyone, welcome to this video from GP Stuff on chest. So, what's your approach to chest pain of any sort? The one I would recommend is anatomical. So think about things from the outside in. So outside you've got your skin. You can have shingles and cellulitis. With shingles, you can have pain 2 to 3 days before the rash actually appears. Beneath the skin, you've got your muscles. So think about spasm. Underneath the muscles, we have the bones with costochondritis and fractures and tumours. Out of these, costochondritis is probably the most common cause of chest pain coming from the bones that we see. Now, inside the rib cage itself, we've got the lungs, so infection, emboli, and pneumothorax are common causes. The most common cause of non-cardiac chest pain happens to be GI stuff. So thinking about reflux and ulcers and esophageal spasm and esophagitis. Now, spasm can mimic cardiac chest pain exactly, and it can even get better with nitrates. That's because nitrates help relax the smooth muscle of the vessels of the heart, and they also relax the smooth muscle of the esophagus when it's going to spasm. Now, other causes of non-cardiac chest pain can be interesting things like Bornholm syndrome, where you have in patients with Coxsackie virus infection, so hand, foot, and mouth disease, it can come in with unilateral chest or abdomen pain with rhinitis, and you give them simple analgesia for this. Aortic dissection is another cause of non-cardiac chest pain, and this would present with tearing chest pain, radiating from the front to the back of the chest. You'll have an unequal blood pressure in both arms, and these patients need to go into hospital right away. Moving on to cardiac chest pain, heart pain itself is in the center of the chest. It's a crushing pressure. And quite often patients will say, I feel like I've got an elephant sitting on my chest, that kind of discomfort. Now, it radiates to the neck and the jaw and the arms, and it's associated with symptoms of autonomic dysfunction, like feelings of impending doom and anxiety and diaphoresis. Now, the pain lasts more than 15 minutes. It's better with GTN spray, and the severity is very variable. So in patients with silent MI, for example, you can have absolutely zero symptoms with a very severe MI, or you can have the opposite where you've got a small MI happening with very severe pain. Moving on to management of cardiac chest pain, this depends on if the patient has pain right now or not. If they've got pain right now, give them GTN spray, 300 milligrams stat of aspirin, and get them blue nighted to a hospital. If they had pain between 12 and 72 hours ago, get them a same-day assessment. And if the pain was more than 72 hours ago, get an ECG, get some troponins, and then decide how to proceed. That's all for this video, folks. See you in the next one, and don't forget to like, comment, and subscribe.